Okay. And then it'll just be those two arrows. Okay. So, hi, I'm Dr. Wood. I think I've seen some of you guys at my last talk. This is pretty much the same talk as I gave you guys in 2017. There hasn't been a lot of updates on cystic fibrosis related diabetes in terms of guideline updates and things like that. But Kat asked me to just talk about where we're at with cystic fibrosis related diabetes and to give a reminder as to how we're treating it currently and things that you can do to attend. So we're going to start by just going over goals and objectives. So you can see that what I want to go over today is to understand the current methods of diagnosis and treatment of cystic fibrosis-related diabetes, understand the role of CFRD in the overall prognosis in patients with cystic fibrosis, and understand our future directions in the treatment and diagnosis of CFRD. So cystic fibrosis-related diabetes is the most common comorbidity of cystic fibrosis, meaning it's the most common thing that is a separate disease that occurs in conjunction with cystic fibrosis. And in patients with cystic fibrosis who develop diabetes, it's an insulin deficiency state with a little bit of a component of insulin insensitivity. So what does that mean? Basically, it means that people with cystic fibrosis are not making insulin in the quantities that they are supposed to be making it. And the reason for that is that well, it's probably twofold. When people with cystic fibrosis are born, when they do MRIs of their pancreases, we see that the pancreas is actually smaller and underdeveloped as compared to a person without cystic fibrosis. So there's probably some component of just being born with less. Then as time goes on, what happens is those enzymes that aren't being squirted out into the gut to digest the food, because of the cystic fibrosis, those enzymes are just staying on the pancreas and bathing the pancreas in the enzyme. And what happens is that enzyme basically chews up the pancreas and it destroys the insulin-making cells. So over time, as a person grows with cystic fibrosis, their insulin-making cells are dying and they become insulin deficient. Some people think that if people have pancreatic disease with their cystic fibrosis, that pretty much everyone, if they live long enough, will develop diabetes. We know that by age 30, about half of people have diabetes if they have cystic fibrosis. And we know that with early intervention for their diabetes, we have improved outcomes in cystic fibrosis care. So this is a chart that basically shows how cystic fibrosis-related diabetes develops. So first you have your mutation here, and because of that mutation, you have exacerbation of your lung disease. And because of that, you're treated with steroids, which is like prednisone. You have chronic inflammation or irritation, especially in the lungs. There's some component of malnutrition or difficulty gaining weight. And sometimes there's infections or increased illness, which is called sepsis. And all of those things make the insulin that you're making not work as well. And this is called insulin resistance. And if your insulin is not working as well, then you develop something called hyperglycemia or high blood sugars. In addition, that mutation makes the thick secretions blocking the pancreatic duct so the enzymes can't get out. That causes fatty infiltration and fibrosis of the pancreas, or destruction of the pancreas, and eventually delayed and dysfunctional insulin secretion, or basically not making insulin as well. So again, it's not making insulin as well, not making as much insulin, and the insulin that you make is then not working as well as it should. Insulin is supposed to take the food that you eat from your blood and put it into your cells for energy. So basically, if you eat, you use your enzymes, you grind up your food, you absorb it into your blood, and then the blood sugar goes into your cells, into your brain, into your heart, into your muscles with the aid of insulin. Insulin's the key that lets the sugar get into your body for energy. When you have normal insulin action, what happens is you eat food and you get what's called first phase insulin release, which is a big spike of insulin that catches that first food that you've eaten, especially those carbs like juices or fine sugars that you've eaten in the meal. And then you make a second phase of insulin that catches up the remainder of the food that you absorb. What happens if you have cystic fibrosis is that you lose the first phase of insulin response. And so what happens here, you can see in healthy controls, if you eat food and you are a healthy person with normal insulin, you get a little spike in your blood sugar and then it comes back down, but it all stays within the normal range. Here's the normal range, okay? If you have a pancreatic sufficient person with cystic fibrosis, meaning a person who does not require enzymes to eat meals, those people get a spike in blood sugar that lasts a little bit longer and then it comes back down to normal. If you have pancreatic insufficient patients with cystic fibrosis who do not have cystic fibrosis related diabetes, their blood sugars spike up quite a lot higher to the verge of being abnormal, stay higher for a longer period of time, and take longer to resolve. In patients with true cystic fibrosis related diabetes, their blood sugars rise and do not resolve at all. The reason why these patients here have an increase in their blood sugar that is longer and more sustained is because of the loss of first phase insulin. So you can see that those people, their insulin is coming out, C-peptide is a marker of insulin, so their insulin is coming out in a delayed fashion. It does not spike up like a normal person should. So what happens as your cystic fibrosis related diabetes progresses from normal to full-on diabetes is that at first you have intermittent postprandial high blood sugars, meaning intermittently after you eat, particularly a high carb meal, your blood sugar will spike. Eventually you develop impaired glucose tolerance. That is detected by an oral glucose tolerance test with a 2-hour blood sugar of greater than 140. So even before that happens though, you're having a spike of blood sugar after you eat, and that can be detected on a 1-hour blood sugar on an oral glucose tolerance test, which not all institutions are doing because it's not part of our current guidelines yet. Then as it progresses further, you get diabetes without fasting hyperglycemia, meaning that you have diabetes, but when you wake up after fasting all night, your blood sugar will be normal, and then ultimately your blood sugar is abnormal all day long. So the difference between type 1 diabetes, which is juvenile diabetes, little kids with diabetes, and type 2 diabetes, which is what I call the older person kind of diabetes, or diabetes that happens with increased weight, and cystic fibrosis related diabetes, is that CFRD tends to look a little bit like a mix of type 1 and type 2. You have decreased insulin secretion, but you also have decreased insulin sensitivity, meaning that insulin that you make works less well. In CFRD, the treatment is insulin, and we'll get into why it's insulin and not oral medications. People with CFRD have a lower risk of having complications that are microvascular or macrovascular, meaning heart disease, kidney disease, eye disease, and so forth. But their main complication is pulmonary disease exacerbation, decrease in pulmonary functions, which we know for the cystic fibrosis population puts you at highest risk for early mortality or early death. So we want to treat cystic fibrosis related diabetes aggressively because we want to save your lungs, not because we're trying to preserve your body from complications of diabetes like a type 1 or a type 2, which can happen but you're at lower risk for, but more because we want to save your lungs. We want to keep your lungs healthy so that you can live as long and as healthily as possible. We know that cystic fibrosis related diabetes is probably more common than we had previously thought. We haven't really, until the past 10 years, aggressively done oral glucose tolerance tests on the cystic fibrosis population, mostly because it's a cumbersome test. It's kind of a pain in the butt. It tastes bad. People don't want to do it. Once we found out that treating cystic fibrosis related diabetes early preserves quality of life and length of life, we started testing more aggressively, and we noticed that up to 9% of 5 to 9-year-olds already have CFRD. By the time you're 20, a quarter of people have it, and by age 30, 50% of people have it, and these may still be underestimating the true prevalence of this disease. Most people, when they start with their cystic fibrosis related diabetes, have no clinical features, meaning they have no symptoms. But some things that might pop up or you might notice if you're starting to develop it is if you're a child, you might have poor growth. If you're a child or an adult, you might have failure to gain weight or failure to maintain weight. Polyuria and polydipsia mean drinking a lot and peeing a lot because higher blood sugars make you thirsty. If you're a child, you might not go through puberty as quickly. You might have an unexplained decline in pulmonary function. More severe complications like diabetic ketoacidosis, which is a severe complication of type 1 diabetes, is really rare. Most people with CFRD do not suffer from that. And many people with CFRD have what's called reactive hypoglycemia, which is having a blood sugar that is low a couple of hours after eating. So to screen for this, what we are doing right now is we are doing yearly oral glucose tolerance tests starting at age 10. We get a fasting and a 2-hour level to diagnose CFRD. If the fasting level is greater than 126 or the 2-hour level is greater than 200, you have cystic fibrosis related diabetes. We do here at our clinic a 1-hour level as well to determine whether you are having increased blood sugars an hour after eating, which is clinically important, and we'll talk about that in a little bit in a few slides. We try to do this test when a patient is clinically well because sometimes it will look like a patient has diabetes when they don't if they are ill because of the increased insulin resistance. But if it's a choice between doing it when you're sick versus not ever doing it, I'd rather have you get a test done when you're sick than just not doing it at all. We know that the oral glucose tolerance test results correlate with CF outcomes. So if you have cystic fibrosis related diabetes diagnosed on an oral glucose tolerance test and you do not treat it, we expect that your lung function decline will increase over the next 4 years. We expect that you might have some microvascular complications like kidney disease. And we know that you have a risk of an increased risk of early death. Therefore, early detection of cystic fibrosis related diabetes is super important because if we can treat you with insulin, we will improve your pulmonary functions and we will preserve your weight and we will likely preserve your maximum lifespan and quality of life. So here's some stats on screening people with cystic fibrosis for cystic fibrosis related diabetes. So the question was, did you have an oral glucose tolerance test if you're age 10 or older? And in 2007, as I mentioned previously, we were screening about 15% of people. In 2012, we were screening about 32% of people. At our institution, we are screening way more than that. I think the last time I saw our stats, it was getting up to 67 to 80%, depending on where people were getting it done. And largely the missed oral glucose tolerance tests that were done were basically because of difficulty getting people to go do it. So I'm trying to make a big push for people to go get their tests done so that we can treat you and preserve your lung functions. Other ways that you can be diagnosed with cystic fibrosis related diabetes are, one, if you're on continuous drip feedings like G-tube feeds, if you have a mid or immediate post-feeding blood sugar greater than 200 done in the hospital on 2 separate nights, that's cystic fibrosis related diabetes. If you are sick and you're in the hospital or on steroids and you have a fasting blood sugar greater than 126 or a 2-hour after eating blood sugar greater than 200 on 2 specific occasions, that is cystic fibrosis related diabetes. And if you're a healthy outpatient, if you get an oral glucose tolerance test with a fasting level greater than 126 or a 2-hour level greater than 200, or if you have a hemoglobin A1C greater than 6.5 or a random blood sugar greater than 200 on 2 different occasions, plus the symptoms of drinking a lot and peeing a lot, then you have cystic fibrosis related diabetes. Pregnancy is another time when you can diagnose it, but I'm going to skip over that because it's a pretty specific type of situation. So I want to make a few comments on the diagnosis of cystic fibrosis related diabetes and why it might be getting missed in you yourself. One, if you're getting a hemoglobin A1C every year and you think that that is adequate, it is probably not. Hemoglobin A1Cs are a blood test that you can do to see how much sugar you've had in your blood in the past 3 months. The way they do it is they take a little bit of blood and they measure the amount of blood that has been stuck to the red blood cell, and then it punches out a number at you. This test is normalized in people whose blood cells live an average amount of time, which is 3 months. So if your blood cell lives 3 months, it has 3 months to gather up blood sugar and get it stuck to it, and then we take the sample and we read how much sugar is on there. A level of 6.5 or greater means that you have diabetes. But in cystic fibrosis, red blood cells live only about 2 months, and so hemoglobin A1Cs are falsely low. So frequently people will get hemoglobin A1Cs and they will be less than 6.5, and they will be falsely reassured that they do not have a blood sugar problem. And therefore they won't get their oral glucose tolerance test. And I would recommend against this. I think you should still get an oral glucose tolerance test, even if your hemoglobin A1C is normal. At the time of diagnosis, patients with cystic fibrosis related diabetes only have an elevated A1C 16% of the time. In terms of random and fasting blood sugar levels, if you just don't happen to get a blood sugar level when it's 200, you might be missing higher blood sugars and you might miss the diagnosis. Some people are using continuous glucose monitoring, which is a monitor you can put on your body and get a blood sugar every 5 to 15 minutes. And this is being used in the research setting, but the current guidelines do not recognize continuous glucose monitoring as a valid way to diagnose CFRD. I will say, though, that it is a very valuable way of assessing whether or not you are having high blood sugars. And more so than the diagnosis of CFRD, I think the diagnosis of having high blood sugars is important for the health of patients with cystic fibrosis, and we'll get to that in a little bit. If you get a oral glucose tolerance test, you'll get a set of results. And this is how we classify normal or abnormal. So you can see IGF, it means impaired fasting glucose. NGT means normal. IGT means impaired glucose tolerance, okay? So you would get a glucose level, and if your fasting level is less than 100, you're normal. If your fasting level is 100 to 125, you're having some impaired fasting glucoses, and that may mean that you're having problems with hyperglycemia in the day. If your blood sugar is higher than 126, then that's a diagnosis of diabetes. With the 2-hour level, if your level is less than 140, it's normal. If it's 140 to 199, it's impaired. And if it's greater than 200, it's diabetes. When we get a 1-hour level, levels greater than 200 are considered indeterminate hyperglycemia. And these patients might benefit from some insulin therapy. So if you have cystic fibrosis related diabetes, we know that early treatment with insulin is recommended. Because if you have CFRD that is untreated, meaning you are not receiving treatment, you have an up to 6-fold greater mortality rate. In the 1980s, 25% of patients survived to age 30 if they had cystic fibrosis related diabetes, but 60% of the non-diabetic group survived to age 30. And now with earlier treatment of this disease, we are closing that mortality gap. So you can see down here, these are the patients from the 80s. And if you look at these graphs, the mortality of patients with cystic fibrosis, blue lines are males, red lines are females. The solids have cystic fibrosis related diabetes, and the dotteds have they're intact. So if you look at these dotted lines here, the mortality rate of patients who did not have cystic fibrosis related diabetes was low. If you had cystic fibrosis related diabetes, your mortality rate went way up, and this line here went way down here because there were no patients that survived in this study group past this age. By the time we got to the early 2000s, this particular group in Minnesota, they had been starting to treat cystic fibrosis related diabetes more aggressively, and you can see the mortality lines started to merge. And now in 2003 and 2008, they got even closer. Their data more recently has not yet been published, but we're hoping that it will be published soon. But the guys in Minnesota have been treating CFRD pretty aggressively, and I think that the mortality rates for those patients are probably approaching the patients that do not have cystic fibrosis-related diabetes. So this is why it's important to you. We have a couple of really small studies that looked at insulin treatment for patients with cystic fibrosis-related diabetes. In this particular study, it was a 3-arm trial. One group got insulin, one group got oral treatment or by mouth treatment for their diabetes, and one group got placebo or nothing. They had 81 patients. 61 of them had CFRD, but they did not have fasting hyperglycemia, so they had normal blood sugars when they woke up in the morning. 20 of them had impaired glucose tolerance, so they didn't quite yet diagnose with cystic fibrosis-related diabetes. And when they looked back, all of them had a loss of body mass index in the year prior to therapy. The group with insulin had that loss in body mass index reversed. In this group, we looked at pulmonary functions, and so you can see the FEV1 and FVC here. And this was the decline that happened in pulmonary functions prior to treatment with insulin. And then once insulin was started, you can see a reclamation of some pulmonary function levels, and then a slower decline, so that 3 years after starting treatment, they were back to where they were when they had started treatment, as opposed to the continuous decline that would have been expected with no treatment at all. Also, body mass index did slightly improve with insulin therapy and was maintained. Then people started to think, well, should we treat before the diagnosis of cystic fibrosis-related diabetes? And I will tell you that the studies that are looking at whether or not you should treat before CFRD is diagnosed are very small. They're not big groups of people, and so we don't have great information. But the information that's coming out is suggestive that treatment before you get cystic fibrosis-related diabetes, when you have some glucose intolerance, might be helpful. The first study looked at 4 patients with a normal glucose tolerance test, but they were having declining PFTs and weight. And they started insulin on these patients even though they had a normal glucose tolerance test, and all of them had improvement in their PFTs and BMI. Another series of 6 patients with impaired glucose tolerance started insulin on these patients, and all of them had improved body mass index and lung function. And then another group looked at 22 children with some abnormal glucose tolerance or CFRD, and they started insulin for a year, and they had improved pulmonary functions and reduced number of pulmonary exacerbations. When they look at whether or not you should do insulin or other treatments like oral agents, insulin, I think, is the clear winner at this point. It's currently the only recommended medical therapy for cystic fibrosis-related diabetes. It's the only medication that's been shown to stabilize lung function and improve nutritional status, and it might even help in milder forms of abnormal glucose tolerance. It is an anabolic steroid, meaning it helps you build your muscle, and it helps you with your nutrition. Oral diabetes agents are not necessarily recommended. There's lack of randomized controlled trials, so we don't have good trials showing that they help. They don't seem to be as effective in nutritional status, in A1C control, or in lung function. And there's some question as to whether some of those oral agents might actually burn your pancreas out sooner. So it might temporarily improve the diabetic state, but at the expense of burning out the remaining insulin-making cells quicker. So some things that we might recommend if we're going to put you on insulin are to put you on a long-acting insulin like Glargine or Detamir. Sometimes if you're on G-tube feeds, we might put you on an intermediate acting insulin for just the G-tube feeds like NPH or regular, which lasts about 8 to 12 hours. Or we might ask that you go on a short acting insulin that lasts 3 to 4 hours right before you eat. Some patients who require higher doses of insulin might go on pump therapy, which allow a fewer number of injections. This is a graph that just shows the length of how long each insulin agent might last and how we tailor that to your particular needs. One thing that I do want to bring up is that patients who have CFRD often ask me if they should change their diet, and the answer to that is generally no. The reason for that is because with cystic fibrosis, you have a large increase in caloric needs. So you really need to be able to still eat the number of calories that you're eating. You don't want to go on a low-fat diet. You don't want to go on a calorically restricted diet. That's not going to help your diabetes. It's my job to tailor the insulin to your caloric needs. The one thing that I would think about changing in cystic fibrosis-related diabetes is minimizing pure sugar drinks like soda pop, Gatorade, sweet tea, if you're drinking a lot of juice, because those things really spike up sugars to a great extent, and it makes it a little bit harder to control the diabetes. So I'd rather that the calories come from food rather than sugary drinks. If you've been diagnosed with cystic fibrosis-related diabetes, you want to be seen by a multidisciplinary team trained in cystic fibrosis and diabetes. So frequently, if you see a general endocrinologist, they may or may not have had specific training in cystic fibrosis-related diabetes. The thing that they seem to miss the most is the fact that you have to be more aggressive with patients with cystic fibrosis than you do with a general diabetes patient. Because our goal with cystic fibrosis is not to minimize microvascular and macrovascular complications as much. People with cystic fibrosis get that much less frequently. Micro and macrovascular complication happen if your blood sugars are frequently going above 200. In cystic fibrosis, you actually want to minimize spikes above 140, because above 140, the blood sugar diffuses into the lungs and starts to do direct damage to the lung tissue, as well as make a home for bacteria. It's a food source for bacteria, so it can increase the number of infections that you're getting. So when I'm treating a patient with cystic fibrosis, my goal is not to keep the blood sugar less than 200 like it is in a standard diabetic. It's to keep the blood sugar less than 140. So sometimes if you see a standard endocrinologist who hasn't had a lot of CF training, they'll look at your blood sugars and they'll see a bunch of 160s, 170s, 180s and think that that is fine. In my clinic, I try to keep it less than 140 to preserve lung function. If you have cystic fibrosis requiring multiple daily injections, you would want to monitor your blood sugars a minimum of 3 times a day. If you're only requiring 1 injection a day, you might only have to check 1 blood sugar a day or a couple a week. Checking your A1C every 3 months is advised, because we do know that if your A1C goes above 7, you do have an increased risk of microvascular complications, and you would also want to monitor your blood pressure quarterly and make sure that the blood pressure stays in range. We start monitoring for microvascular complications like getting a urine sample to check for the kidney disease and getting eye exams after 5 years of the diagnosis of CFRD. This is some goal blood sugars for patients with CFRD as published by the current guidelines. So fasting blood sugars 70 to 130, 2 to 3 hour levels less than 180, and bedtime levels 90 to 150. In my clinic, I actually try to run it even tighter than that, with fasting blood sugars less than 100 and 2-hour postprandial or after eating blood sugars being less than 140 as much as possible. Because I think that most likely preserves lung function. And if I can do that without causing excess low blood sugars, then I will keep those blood sugars a little bit tighter than the recommendations. If you have been hospitalized with cystic fibrosis, you're at increased risk of having high blood sugars during that illness, because during illnesses you might be treated with prednisone, or you might be having some more insulin resistance just from the inflammation of your illness, or you might be started on enteral feeds, meaning G-tube feeds or NG feeds, or you might have had surgery. And so we would increase your blood sugar monitoring when you've been admitted. Oftentimes, if you don't have CFRD, I'll check a blood sugar before meals and 1 to 2 hour after meals to see how you're doing in the illness setting. Survival and prognosis of CFRD. If you have cystic fibrosis-related diabetes, we know that is correlated with worse lung function, poor nutritional status, and decreased survival. Again, when they looked at 448 patients who were followed for 10 years, those patients with cystic fibrosis-related diabetes had a 25% survival at age 30, and 60% survived if they did not have CFRD. When they monitored those patients, they saw that their clinical status declined 2 to 6 years before the diagnosis of diabetes. And so knowing that in my clinic, when I start to see pulmonary function decline or nutritional decline, I really start thinking about glucose intolerance, and I think about treating with insulin even before the diagnosis of cystic fibrosis-related diabetes, because my assumption is that if you start insulin earlier, you might be able to prevent that decline. They're doing current studies on that, but those are not released, and the standard guidelines have not been reflecting my hypothesis yet. But I will tell you that at my institution, we have one of the best body mass index rates in the whole country. And I think that might have to do with our more aggressive treatment with insulin. When we look at standard diabetic complications, if you've had high blood sugars for more than 10 years in a fasting condition, meaning when you wake up, if your fasting blood sugar is higher than 126, 14% of those patients started to have kidney disease, 16% started to have eye disease, 55% started to have nerve disease, and 50% started to have gastropathy, which means poor movement of food through the abdomen, through the stomach, and through the intestines. People who did not have fasting hyperglycemia as part of their disease, as part of their cystic fibrosis, did not have any microvascular complications. Most of the people who had complications had A1Cs that were maintained greater than 7 for the long term. So far, macrovascular complications like heart attack have not really been reported in the cystic fibrosis-related diabetes population. So again, complications of cystic fibrosis-related diabetes are increased protein catabolism, meaning weight loss, worsening pulmonary function, fatigue, increasing in blood sugar, increasing in mucus viscosity, meaning thickness of your mucus, and increase in infections, increase in infections because of that thickness of your mucus, also because of having a food source for the bacteria, and also because your white blood cells work less good in a state of high blood sugar. So in the future, some of the things that have been changing are the event of ivacaftor or Combi, and some of these other new medications that are being used to treat cystic fibrosis. These medications actually might also work at the level of the pancreas, preventing or delaying the onset of cystic fibrosis-related diabetes. They're really too new to see how they are affecting blood sugars, but clinically what I've been seeing after a start of Orkambi is that about a year later, many, I would say 60 to 80% of my patients on Orkambi, their insulin dose have been going down. So I'm hopeful that these medications will prevent or delay the onset of CFRD. We also have devices such as continuous glucose monitoring, which is a device you can wear in your skin to help you monitor your blood sugars. You can see that the blood sugars can be monitored minute to minute. You can really get an idea of what your blood sugars are doing. This is a patient who had high spikes of blood sugars multiple times per day. And after wearing that device for a week, they changed the way that they were behaving in terms of eating and drinking, and you can see that those blood sugar trends changed over time. So that might be informative for you. It might help you have the energy to cut out things like soda pop or to start insulin and treat blood sugars. Insulin pump therapy is this, and it allows you to have direct administration of insulin into your skin on a continuous basis rather than giving shots. So using continuous glucose monitoring, there's been a few studies that have just started coming out using this as a determinant of whether or not you would be at risk for cystic fibrosis-related diabetes. And people who wore CGM and had blood sugars greater than 200 had an indeterminate or cystic fibrosis-related diabetes diagnosis on their oral glucose tolerance test within 2.5 years. Also, patients who had blood sugars greater than 148 on their 2-hour OGTT or CGMs with blood sugars greater than 140 more than 4% of the time had declining weight and lung functions in the preceding year. So we might be able to use this as a tool to identify patients who should be started on insulin earlier. The foundation will be taking this research and updating their guidelines as they see fit according to the research, but the research really needs to be more powerful. As you saw, most of the studies that are coming out are done on very small quantities of patients, which don't really allow the experts to make sweeping recommendations for all patients. The other thing that they're doing is they're looking at some other oral agents to see if we can do some oral agents instead of insulin that might be helpful. And they're looking at changing the diagnosis criteria for oral glucose tolerance tests. All right, I think, oh yes. So this is the last thing that I wanted to show you. This is a patient example. This is a 13-year-old boy who had oral glucose tolerance test. His fasting was 94, which is normal. His 2-hour was 152, which is a little impaired, over 140, but not over 200. His A1C was 5.4, but his 1-hour level was 197. And when they did a continuous glucose monitor, you can see he had frequent spikes of blood sugar greater than 200. The decision was made for this patient to start insulin, and you can see his body mass index rose precipitously after he started on insulin. So it's patients like this that give me hope that with the addition of insulin, we can improve health, improve body mass index, improve pulmonary functions, prolong life, and improve quality of life by decreasing the hospital admissions. I think that's all I have to say. Kat's going to come in and turn it on so I can hear you guys if you have questions.
Oops. Okay, maybe just stop sharing. There's like 40 feet. Okay. So, okay, can you guys hear?
Can you hear us?
Yeah. Okay, so if you have questions, just unmute yourself.
Hi, Dr. Wood. I'm
Hi.
Amy. Hey, hope it's okay if I jump in here.
Absolutely.
I just want to thank you so very much. This presentation and the previous one you did a year ago, I think it's no exaggeration to say it changed my health and my life. I think I had great support at my CF center, but I think for whatever reason, this information doesn't necessarily get disseminated as well. And I was able to, you explained it in such a way, I was able to kind of collaborate with my CF team and incorporate some of the changes, and my lung function has gotten a lot better. I'm sick a lot less often, and I just, yeah, I have a CGM now, which is like a whole new world to understand what's really going on in my body. So I can't thank you enough. Thank you for taking the time to do this.
Oh, great. I'm so excited for you.
Yeah, it's great. I've referred the video that you and Kat have to so many other people.
That's great.
You have to watch this. You have no idea all this stuff that's going on in your body. I have a quick question though about red blood cells, A1C, and obviously with my CGM, I'm able to get kind of an average of what my glucose is, and it seems to correlate pretty well with my A1C. Does that mean maybe my red blood cells are living 3 months? Could something else be going on? Just out of curiosity, if you might know.
Your red blood cells are probably living close to 3 months.
Huh. That's interesting. Okay. Yeah. It's a great fact, though, to know, though, about 2 or 2.5 months for most people with CF.
Yeah, and when I do CF patients, if I have a disparity between the A1C and the CGM, I usually believe the CGM a little bit more because it's, hard facts. You know exactly what those blood sugars are.
Yeah, great. Thank you so much again. I really appreciate it.
No problem. Anybody else? Yeah, I don't think I have any questions.
I know. Okay.
I do have one question. So hi, my name's Jillian, by the way.
Hi, Jillian.
Thanks for your awesome presentation. I also watched it a year ago, and it's fascinating to relearn it all again. I don't think we can ever have too much of this education. No. Okay. Sorry, distracting toddler. So I wondered if you could speak a little bit more about Orkambi and Symdeko, and maybe that you don't know a whole lot about it yet because they're so new, but maybe the effects that they're having on CF-related diabetes. I've been on basal insulin since 2011, And my blood sugars were getting, I was getting a lot of lows while I was on the insulin after I switched to Symdeko. And I've recently stopped all insulin and have just been monitoring my sugars really closely. Which is like mind-blowing to me.
Wow.
So I've wondered if you've seen that often, if that's a common occurrence that I should just kind of like get used to, or maybe this, I don't know what to expect, like as I take this longer.
I have not had a lot of patients on Symdeko yet. I have heard reports that both on Orkambi and Symdeko that some patients have come off of insulin therapy. The theory behind that is that there is probably an actual dysfunction in your pancreas that is just innate to CF, and that when you're on those medications, that dysfunction is repaired. So if your CF hasn't killed your insulin cells, if you still have them, then the theory is that those medications will make those remaining cells work. So if you have enough cells left to pick up the slack, like if you cut out half my pancreas, the remaining half would do what it needed to do. So if you have, some quantity of cells left, the hope is that these medications will make those cells work and that you will make enough insulin to not need further insulin therapy. If you are born a CF today and you get started on one of those medications before you get CFRD, the hope is that those patients will not suffer from CFRD at all, or maybe to a much decreased effect. But we don't know that to be true. There's no study that says that that's happening. There's just these reports of people like yourself where that this has happened. Clinically, on Orkambi, I've seen a couple of patients with some drastic decreases in their insulin. I have had no patients come off completely. I've had a few patients who've had absolutely no change. I imagine that if the pancreas has been destroyed to an extent where there's nothing to save, then those patients aren't going to have improvement. But my hope is that with these newer medications in each generation, that we're going to see more and more response. So fingers crossed, you will have a prolonged effect where you won't need insulin if you stay on this medication. But we actually don't know. We don't know if in 10 years, like it just made things better for a while, or if it slowed the decline and loss of pancreas cells. We just don't really know. Man, I hope and pray for you that you stay off the insulin as long as possible. That is so awesome.
I am like just flabbergasted that it's going well. Would you recommend like I think this is new for everyone, so like any sort of follow-up besides monitoring sugars closely to make sure that we're still in like good control, and because I responded really well to the insulin I was taking.
If you were my patient, because I'd be really curious about you, I'd throw a continuous glucose monitor on you twice a year and see what happened. And just see what.
Sounds like fun. Let's go for it.
I would say just do it. And that would probably identify some intolerance a little bit faster, even than oral glucose tolerance tests. If you had stopped doing oral glucose tolerance tests because you were on insulin, I would start doing them again every year. Just because I would kind of put you in that category of like diabetes in remission, I guess, maybe, and see if you could identify trends like is your oral glucose tolerance test getting worse again at some point, or is it staying good? Honestly, though, there's no recommendation for people like you. There is no recommendation. That's just what I would do, and I would do it out of curiosity and out of the desire to catch some insulin intolerance as fast as possible in you. To put you on insulin as soon as you needed it, rather than wait 5 years too long because it's supposedly fine. Yeah. So that's what I would do. I'd do an oral glucose tolerance test once a year, and I'd throw a CGM on you once to twice a year and see what's happening. Yeah.
Awesome. Well, thank you.
Yeah, you bet.
So we have some questions from the website, unless anybody else has anything. Brian does. Okay.
Can I ask one? Oh, Brian did.
Sorry. Yeah, I just had a couple quick questions. One, I was in the seminar last year with you as well, and that was right when my CFRD was kind of being diagnosed to begin with. So what my question is, it's been under pretty good control throughout the last year and a half. But my question is, I started off with the long-acting low doses. I think it was like 1 or 2 units right at the beginning. And now I'm up to like 9. and still using the short acting with high carbs and stuff like that. My question is, I don't have any of the new pills available to me, the Orkambi or Symdeko or any of that. Would it be normal to expect that to still increase since my pancreas is so damaged, or not?
Yeah, absolutely. I would definitely expect your dose to increase because
Okay.
it's a progressive disease, so it'll get worse.
Right.
So what I usually see in patients is you were actually started on a teeny little dose.
Right.
Your size, if you were on a full dose, you could be on upwards of 20 to 30 units of Lantus.
Oh, wow.
Yeah, in addition to short-acting insulin. So you're still actually on a pretty small amount. Like,
Okay.
when I start a person, if I'm being really ginger, 0.1 units per kilo. So, an average male is about 75 kilos or 80 kilos. And so that would be about 8 units as a start dose. So your 1 to 2
Gotcha.
units was teeny. And now you're on sort of like a standard start dose. So whoever
Okay.
started you is starting you early and aggressively and doing a good job. That's good.
Okay. Cool. Thank you very much. I really appreciate your seminar.
If I could pipe up one more time, if that's all right. Obviously we all talk a lot in the community, and I just talk to various people who get their OGTTs and their 2-hour postprandials, or 180, and maybe they are lucky enough to get a 1 hour that are 200 or above, and they're frequently told you're fine, even though their lung functions are plummeting, they're losing weight, they're lethargic. If you were to be able to speak, it's not my case obviously, but if you were able to speak to these people directly, what kind of advice would you give to them to be able to advocate for themselves to basically hopefully preserve their lung function?
Yeah, right. So it is the current guidelines state, that you have cystic fibrosis related diabetes if your 2 hours greater than 200. So, if people are going straight off of guidelines, that is the advice that they'll give them. But like you said, if their pulmonary functions are declining and their body mass index is declining, and we know that in people who have started insulin, we have seen improvement. There's not a lot of downside to starting insulin except for it's a shot and you could have low blood sugars. What's the downside to giving it a try? So I basically say, hey, we know that decrease in pulmonary function and decrease in body mass index occurs several years before cystic fibrosis related diabetes. We know that insulin improves those things. Can I give it a shot at a low dose? Can we try it? Especially knowing that blood sugar diffuses into the lungs above 140. So, I usually throw out those couple of facts, and most people who at least see an endocrinologist, their endocrinologist will be like, you want to try insulin? Okay. That's fine to me. If they're seeing people who are not endocrinologists, they might not feel as comfortable. So if you're not seeing an endocrinologist, you should probably at least try to see an endocrinologist. And if you can, see one who has some experience in CFRD. Yeah.
Thank you so much again.
Yeah, you bet.
Anybody else? Okay, so Sarah is wondering, she said, I usually have too low of blood sugar, around 50 once a day. Is that going to damage anything in the long run? The problem is that usually I can keep pretty stable numbers, but sometimes I think my body releases more insulin and I get low. I'm torn between having a low once a day or having generally higher numbers like 150 or so.
Okay. So that's super common, especially in the beginning of the progression towards CFRD. What happens actually is that you're missing your first phase of insulin. So instead of grabbing up that initial food with the first phase of insulin, your body's trying to do it by making an increased second phase of insulin. So it's not making that big initial spike of insulin, and then it's increasing the second phase of insulin, and it's too much for too long. So about 1 to 2 hours after eating, you actually go low. So your blood sugar comes up, your body overcompensates, and then you go low. So a couple of things that you can do to mitigate or decrease that are, one, you can try to combine proteins and carbs. So try to avoid just simple carbs at a meal. So try to combine your proteins with your carbs so that you have slower absorption of your sugar. So when you have that second phase insulin that lasts longer, you actually have sugar to absorb to eat it up so that you're less likely to go low. The second thing that you can do is a lot of times I'll put people on 1 unit of insulin prior to high carb meals to basically give them a first phase insulin so that their body doesn't have to make such a huge, robust second phase insulin. So, you might notice that it happens more with meals where you have more than 100 grams of carbs or meals that are more carb heavy. And I usually talk to patients about that. And if they notice that there's a specific pattern to it, we give a unit of insulin just prior to those types of meals to try to avoid the hypoglycemia.
Can diet affect whether or not someone gets CFRD?
Diet does not affect whether or not you get CFRD. It's really insulin loss. So it's unlikely that you're going to get cystic fibrosis related diabetes because you ate like crud. Now, you are not immune from getting type 2 diabetes. So eating like crud can give you type 2 diabetes even though you have CF. But what I recommend is that you eat your cystic fibrosis related diet that is prescribed by your nutritionist, and that if you need insulin with that diet, that we give you insulin to cover your needs calorically rather than have you decrease your calories or change the way you're getting calories. Again, with the only caveat being trying not to eat too many sugar pops.
Perfect. Does CFRD have to be regulated with insulin, or can it sometimes be regulated with diet and other medications?
So other medications, again, have not been shown to help. There have been a few studies on some medications that help you release insulin that show that it might help temporarily, but then it actually burns out your pancreas sooner, so you progress to full-blown CFRD sooner, requiring insulin. So I usually don't put people on oral medications. People who just naturally maintain a diet heavier in proteins and fats and lower in carbs tend to be able to avoid insulin for longer. I'm really careful about saying that because I don't want you to go on like a keto diet or something like that. That's just a bad idea. But I have patients who have CFRD by testing, by oral glucose tolerance testing, and they sort of live clean, I guess, and don't drink pop and don't drink a lot of juice and don't drink Gatorade and don't drink sweet tea and they don't eat candy and they eat good, healthy, balanced meals, and they've been able to avoid insulin. So I will carefully say that with diet modification, you might be able to delay insulin, but I would really encourage you not to change anything about your diet without talking to your nutritionist first. Don't change your diet because you have CFRD. Talk to your nutritionist and do what your nutritionist says and take insulin to cover your needs instead.
Perfect.
Any other questions?
Amy, you don't have anything else? Come on, sweet girl. No, I'm just kidding. You know they're all hiding in there.
I'm just excited. I'm just happy. Yeah. Can I ask about the use of CGMs maybe in the future versus OGTT for diagnosis? I mean, it seems like, I know for myself, at 6 years ago when I was first diagnosed, I was passing OGTTs with flying colors, and I was still having, and this was like strict guidelines, 160, 150, 2-hour postprandial, but I started to test at home and I'm like, ooh, sometimes I'm getting these highs, sometimes I'm not.
Yeah, they really are just going to need to have the studies to support it before they change it through the foundation. And really, until they change it through the foundation, nothing is going to change, because everybody follows what the foundation says. But these earlier studies, they're promising for using CGM. So I do think that those guidelines are probably going to change, but basically what they have to do is two things. One is they have to prove that CGM is a valid way to diagnose it, and two, treating off of a CGM is both safe and effective so that it actually affects change. And that there's not a lot of people with cystic fibrosis and cystic fibrosis related diabetes in the country, and so to get the numbers to prove that, it just takes a while. It just takes a long time. Yeah.
Those darn p-values.
I know it. It's tough. So then you need to find rogue endocrinologists like me.
Or patients that are willing to inform them.
Like Amy.
She's not joking.
No, awesome. Okay.
Thank you.
Yeah, you bet.
All right. Well, thank you guys so much for coming. And we'll talk to you guys in group.
Okay, talk to you later. Bye-bye.